Tim stepped out. He should be back in a minute. Just
Okay.
around 3:20, so hopefully he doesn't get his notes. So he's more of a better.
Well, do you want
he's a
to
better
just give a
advocate.
little bit more introduction about the work you've been doing and how you came to the center?
Yeah, sure. So I'm Jim Yates. I work for the Michigan Center for Rural Health, doing the IREACH program, which is improving access to healthcare for veterans, their families, and caregivers. And then I also coordinate the UP Together with Veterans program, which is a suicide prevention program. That's a nationwide program, and we have one chapter up in the UP. There's about 35 chapters around the country. So it's a grant through the HRSA program, a 3-year grant. So I'm on year 1.5 now. And hoping to be able to continue it somehow, some way. So we'll see. So how are we advancing this tapping that?
There you go.
Okay. So basically just a broad view of what IREACH does. Basically, our goal is to connect providers with veteran resources and also connect veterans with those resources as well, and then connect those providers and veterans. Just that overall, getting everybody connected with all the resources, knowing who's needing what and how we can get them hooked up, and promoting other agency programs as well. So just tapping right there. So today we'll go over a few topics that we've identified as, areas where community providers seem to have the most questions or concerns regarding veterans health care, and community care procedures, and areas where the community providers can better serve veterans, and ways in which this information can benefit your facilities and also you as the providers. And did he get in here? Where did Tim go? Hello. So he's my VA backup. Tim Ellison is going to be helping present information. He's with Iron Mountain VA. He's a public affairs officer down there. And so before we really dive into it, a quick look at the population of veterans nationwide and in Michigan. Michigan is one of the largest population of veterans in the U.S., ranks 12th overall. And that's kind of significant considering we don't have any active duty bases in Michigan. So it's all National Guard reserves, maybe a couple active duty that are stationed here for whatever reason. So a lot of them basically out in the community and not just at a actual, active duty base. Of these veterans, less than half are connected to all their earned benefits. And that's where we're hoping to help us out, get them connected. And that's just a matter of usually a lack of awareness on how to get started in getting connected with those benefits. And so since we always need help finding those hard to reach, unconnected veterans, especially in rural areas, a lot of them have gone to rural areas because they don't want to be connected or found. So we want to dig them out of the woods. And we're asking care facilities to help us identify and find those veterans and screen them for, any situations, any help that they could need, that they could use, because you're in the best possible position to work with that. For considering your existing screening process, everybody that comes into your facilities are getting screened for this, that, and the other. You could screen them to ask them if they've ever served the military and if they need any help with benefits and resources. Kind of the example I use is that we could ask grocery stores to do that because everybody goes to the grocery store at some point too, but that's not going to work real well checkout line. Or auto mechanics, everybody's got to get their car fixed, but what kind of professional skills does the average auto mechanic and service attendant there have compared to what you have to be able to help them with the needs that they're maybe presenting? So, so this concept is a national movement with national programs such as the Governor's Challenge and the American Academy of Nursing's Have You Ever Served program. And just to name a few other supporters, the American Medical Association, National Association of Community Health Centers, the Healthcare Association of Michigan, and the Michigan Health and Hospital Association. So it's not just something that we dreamed up and we're trying to get going. It's a national program with all kinds of national support. So when screening for military affiliation, it's important to ask that question in a way that's very inclusive. I didn't realize until I started working this program that many of those who have served don't identify as being veterans for whatever reason. Maybe they just don't like that term. Maybe they didn't serve in combat, they didn't deploy, whatever the case may be. So instead of asking, are you a veteran? It's better to ask, for example, have you, a family member or someone in your household ever served in the military? And that's just more inclusive. And when someone does identify as having served, we have a toolkit to help you with those referrals and what to do next when they do say, yes, they have served. And so I should also note that some of those folks that are providing care for veterans don't identify as caregivers because they don't have a certificate, they didn't go to a specific course. They're just the spouse or family member that's helping with those caregiving services. The VA has, programs out there to provide help with that and support for caregivers. And so that question also needs to be formed properly, so you're including more of those that might be providing care, but they don't identify themselves as caregivers. And funding allocations is another important reason to document how many veterans have been served. So if we can show a significant number of veterans are seeking care, there's a greater likelihood of receiving program funding. And for example, a facility of the screening process, a facility in Iowa thought they were serving about 50 veterans. That was 50. So this data came from the way that they were asking. Maybe they're looking at insurance that they were using, the patient self-reporting as having served, or some other passive way of identification if they had a ball cap on or Army shirt or something like that. But when they began properly screening for veteran status, they found they were serving over 550. And likewise, a facility in the Upper Peninsula thought they were serving about 60 veterans, 60. But when they were, but they found they were serving now over 390 in the last 6 months that they started implementing that question. So, and of course, beyond the tremendous positive impact this had for those veterans, of which about half requested additional information and resources and referred to those programs, whether it been for not just health, transportation, education, whatever it may have been, all the services that the VA can provide them. So not only did it impact the veterans, but it also improved these facilities' needs assessment effort, gave a more accurate patient characteristic report to the UDS, and assisted with patient payments. Because in some cases, the veteran may not have had good insurance or any insurance, but now we've identified they're a veteran and get enrolled in the VA. Now those payments can be made by the VA instead of the facility just, eating that bill. And so plus, it's beneficial for the provider to know if the patient has served because of the unique culture, possible exposures, and common medical conditions of military service. And so for generations, veterans have returned from deployments with an array of unexplained health conditions and illnesses associated with toxic exposures and environmental hazards. And so even domestic exposures are very common, such as the contaminated water at Camp Lejeune, Fallon, Nevada, Hawaii, the list goes on. And so unfortunately, toxic exposure has become synonymous with military service. And so those conversations need to include family also, especially with more findings of generational effects of toxic exposure. And toxic exposure being, big one you probably heard about is Agent Orange, but there's a lot more out there besides that. And I have some of them listed up there. And so then presumptive conditions, and Tim, who's joined us there in the back now, glad you made it back. Don't worry. All right. He knows all this stuff inside and out. I don't know how many years he's been doing it, but I'm learning as I go. So presumptive conditions, the VA automatically presumes that certain disabilities were caused by military exposure. This happens when sufficient evidence is found to support a link between exposure and condition. So if a service member is in a certain place at a certain time and has a certain condition, it's automatically a service-connected condition. And so unfortunately, sufficient evidence means that there's already been a significant amount of veterans that have been in that certain place at a certain time and diagnosed with a certain condition. So here's an example. And you may have heard of the contaminated water at Camp Lejeune. So I was recently speaking with a provider who many years ago went on his way to help a veteran. He came in with, presenting with different, anyway, he was diagnosed with esophagus cancer, which was, this provider told me was very rare for this person's age and situation he was in. And so not very many people at that time had heard about the contaminated water at Camp Lejeune. This provider kind of dug in a little bit and found out that this person had been at Camp Lejeune and did some research and then found out that, okay, that's probably what caused his esophagus cancer. So he reported that. got the veteran enrolled in healthcare. At that time, it was not a presumptive condition. But, because that provider was able to prove, or I know Tim knows the exact terminology there, but he proved basically that that was what caused esophageal cancer. What else could it have been? Because it's just rare to have it. And so he was able to get enrolled in VA healthcare. And then, of course, that data that was provided to the VA regarding that, along with many others, then, you know, they had a lot of cases coming in where people at Camp Lejeune have these certain types of conditions, and so now it's a presumptive condition. So that's how, just an example of how providers can help us with those types of things. And so those last three slides don't include all the presumptive conditions. There's over 200 of them. And so also conditions don't need to be presumptive for the veteran to be eligible for disability compensation. And so that just, you know, that story highlights how healthcare providers can impact future legislation, such as the PACT Act. So the PACT Act is, maybe I need to go back one, I think I'm off one slide. So the PACT Act is big news in the veteran community. Yes.
Can you tell me what differs possibly in this program and others? Because I've had like a lot of local farmers in our rural area, and so they own property. So I had a gentleman that owned 158 acres, but he only earned $700 worth of income a month, but was a veteran. And I couldn't get any services for him at all. I could get absolutely nothing because he owned that property.
Some of that has changed. I know Tim can certainly answer that a lot better.
Yeah, so it's not so much that he owned the property, he was probably taking home $7,000, but if he doesn't have it, so. Not all veterans are eligible for VA healthcare. Some veterans do have to meet an income requirement if they're ineligible under other things. Farming, I just ran into this with a guy up in UP. Farming is very tricky because most of them don't have LLCs or don't have businesses, stuff like that. It's just Bob's farm, and Bob's pulling in 200, 300,000.
Tim, I don't want to interrupt you. If you want to come up here, so where you're talking into the microphone.
Oh, I'm
So the folks online can hear you as
Yeah, I
well.
apologize.
No worries.
I wrongly assumed that they would give you poor people a break before the transition. I'll sit out there till I see a bunch of
Me,
people.
I don't give breaks.
I see, yeah.
Yeah.
I was sitting right out there just going like, golly, they're going to run late. But yeah, so the farming gets really tough because on paper, that person's probably making six figures. In reality, they're taking home $700 a month.
Yeah, but no, was 96 years old. He hasn't farmed his land in many, many years and only had $700 worth of income
I would
a
love,
month.
I would love to look at that because it sounds, if.
Well, he's deceased now.
Okay.
Well, that's because of.
Yeah,
But no, that's what I find a lot in our areas, because we're farmers.
Sure.
We have a lot of, you know, people own a lot of land, and it just seems like nobody can get the benefits because of that. I even had a guy once that just because he had an outbuilding, couldn't get a benefit.
I'm not sure what benefits.
Now
So
that-
when it comes to healthcare,
Any type of VA,
yeah, so when it comes to healthcare specifically, it is just income. It's not asset. So I can own $10 zillion worth of land, whatever. If I only make this much money, I'm fine. But if that is income or I'm getting money from it or things like that, then healthcare will look at that. Now, there
well,
are
he did
other,
rent his property, so
so,
he probably had at least $6,000 in income from renting his land,
oh, that would definitely do it.
so that. would
Yes,
probably-
yeah.
Okay, I didn't think that.
Yeah, so if it is income based, there are a million other programs that are more asset based, like we've got pension programs for low income vets, stuff like that. To bring them up to the poverty level, but that would look at assets. You can't own 150 acres and get a subsidized income through VA.
Because I have to change my way of thinking about this, I guess, because I'm one that will slam it down real fast by telling the patient, you're not gonna qualify for anything, so there's no sense in going.
So this PACT Act is massive and they just opened up a heck of a lot more March 5th. So people that applied and were told, oh, you make too much money, they might have new eligibilities that have nothing to do with income, just based off of where they served, what they were exposed to, what they did in the military.
So to reach out, we should, because we have a local veteran at our,
Veteran Service
office.
Officer.
Yeah, so we reach out to him, or we reach out to the Michigan Center for Rural Health.
So I actually have a phone number in my slides for you. It's our national enrollment center.
Veterans don't even have to fill out paperwork. They can just call them, they can verify their service right over the phone and get them enrolled. And then kick that information over to the local hospital. What county are you in?
Montcalm.
Okay. I was just at the Veteran Service Officer Conference last week, so I've met a ton of VSOs from down here, so, but I don't know off the top of my head who that is.
Right, his last name, I can't remember his first name, right?
And of course, that phone number that he's talking about is just for healthcare, then the VA has all kinds of other services too, that maybe the VSO could help them out with. Other benefits and compensation,
Right.
education, whatever it may be. So, yeah, certainly nothing wrong with getting a hold of the VSO as well.
Right,
And sometimes they know about local resources too, maybe to help the veterans.
are they
Not all
aware of
other
this?
things. Yes,
Okay.
yeah, definitely, yeah. And as you see on the data up there, that's why we're going back out on the streets again. This PACT Act came out a year and a half ago, and that was big news. There was millions more veterans eligible now because of this new PACT Act that was released a year ago. Now Tim's in mine, now I'm in the Tim's presentation, but anyway, so then all of a sudden, come March 5th, they opened it up and even expanded even further. So now we got to go back to those veterans that we talked to before March 5th and say, hey, if you were previously denied even up before March 5th, now you're probably eligible. So a lot of big changes. So yeah.
Yeah, you really need you need the buy-in from people like this in this group, because how else are you gonna reach them? It's no different than selling Medicare insurance on TV. Nobody listens to it because they think, well, that's not real, right?
That's why we're here.
It's
Get ready to buy
big
it,
news.
everybody.
It's a perfect time because we're,
Yeah,
a few months after, March 5th wasn't that long ago, so. Yeah, so we'll just continue on here. Yeah, great question, conversation. Don't even know, so I think that covers that PACT Act. All right, so a couple quick success stories, if you just want to, I might want to read them real quick, but anyway, there's, on how real life situations where providers helped, folks get connected. 92-year-old woman was asked, and she acknowledged having served, so she was referred to the VA and received assistance for their in-home care needs. A man in hospice with lung cancer had never, applied for anything. Of course, he was found to be connected with, you've heard of those things on the news about asbestos too, especially in the Navy. So that's another popular condition. So he had never applied for disability, but then he got linked up with it, and now his widow receives pension based on his disability. Of course, like I say, he's already in hospice. And then there was an older woman that was asked, and if she had served, and she was, or she hadn't, but she was a military widow. So that question, again, being more inclusive, you were someone in your household or family member. And so then she was able to get connected up, and she's receiving another $300 a month more than what she previously had, which was significant for her. So those are all great examples, but as you can see, it was a service member in hospice, a 92-year-old woman and another older woman. So it would have been really nice to get them connected a little bit sooner than that, before they're 90-some, and then really in need. And then also, I didn't realize until I looked at my notes just last night that, I don't know if I did this on purpose when I created this presentation about a year ago, but if you look at I don't know, there's usually that stereotypical veteran, the old gray-haired guy with the Vietnam veteran ball cap, right? But look who's getting connected up here, 92-year-old woman veteran, a spouse. And then, of course, that man that was in hospice, it was his spouse, and it got connected as well. So 2 women, and actually all 3 women were getting connected up with the services VA can help them out with.
so do you guys have brochures or something that we can put in our office as well?
Yes, I'll have a table set up out here with all kinds of good information. So, and then, of course, we have lots of stuff on our website too, on Center for Rural Health's website. All this is on there. So we'll need to speed through some of this. Over half of all veterans enrolled in VA are enrolled in VA healthcare. And we're trying to increase that number. And of course, now that there's more eligible, that is going to increase. And so over 1/3 of them receive care in the community. So that's another kind of misconception, I think, amongst some of the community providers is that, oh, they serve, they're a veteran, they're getting everything through the VA. Well, in many cases, they might be getting services either at the VA hospital, VA exclusively, or they're doing a combination care of VA community care. Maybe they're only being seen in the community at all, never been to a VA hospital or community-based outreach clinic. It might still be VA care though, through the community care provider network. And so, more in-network providers are needed through Optum because just like everybody else, VA is shorthanded. And then, of course, talk about the rural areas, that's what we're here for. Sometimes that distance is a barrier as well. So the Mission Act of 2018 established the community care program, and that's through Optum as that third-party provider for that. And they've been doing a very good job of improving some of the concerns and issues with billing and timely payments and things like that that previous networks had. So we're trying to get that message out there that maybe your facility had a poor experience many years ago, 10 years ago, whatever it was, with whoever the providers were at that time. But there's a new provider in town and they're doing much better with customer service. Get through here a little quicker than. Yeah, so they're addressing some of the biggest challenges providers have in the past, like I said, referrals, scheduling, care coordination, claims processing issues. They're making more timely payments, prescriptions are easier, more types of service providers can participate in community care network. And then just real quick, a quick plug for the UP Together Veteran Suicide Prevention Program. That's a program that we're getting out and doing outreach programs with. We're doing resource fairs all across the UP. It's just it's a UP program. The one that we're coordinating is anyway. And so we've had healthcare facilities help us sponsor some of those events. We have hundreds of vets come there and they get all this information. And then, of course, all the other providers get to network amongst themselves. So that's been working out real well. And so we just want to be that connection between the folks you see on the left here, and then you folks on the right there, that care facility. And let me see how we're doing on time before I turn over. Okay. Maybe I
20
can
minutes.
share the one more nice success story that I have here. So decades ago, there was a Vietnam veteran who was suffering from PTS, but he didn't know it. And so he's going through a lot of trouble. He had a very poor experience in Vietnam. So he just basically tried to cut all ties that he had with the military. He even said when he was at a parade and the veterans were walking by with the flags, he just turned his back and didn't want anything to do with any of that. Just, that was his stance on it at the time. And then, the situation just progressed. And he said one day he found himself in the woods with his pistol in his mouth. And so luckily he did walk away from that situation. And then somewhere along the line, someone handed him a brochure. Look for brochures and information, right? So someone handed him a brochure on PTS and what all the symptoms were. And he started reading through it. And he's like, wow. He said, he realized that he had all of those. And so he decided he needed to get some help. So he got some help and, he accredits that person handed him the brochure and his therapist was saving his life. And now he's one of the greatest advocates for veterans in Michigan. He's doing all kinds of things statewide. He's involved in all kinds of service organizations. He's going out in the woods, dragging people into the veteran service officers and saying, hey, you need to get signed up. You need to get down over to the vet center, get counseling, get enrolled in VA, improve your situation. He does that based on his previous experience. So that's just kind of a nice success story there. Someone just helped him out and now he's been out there reaching out and helping out many others. So with that, I'll turn it over to Mr. Tim Ellison with Iron Mountain VA, and your slide should be right after.
Perfect.
There you go.
All right, like you said, my name is Tim Ellison. I'm the Public Affairs Officer for the Iron Mountain VA Hospital. A lot of my slides are actually set up. I'm assuming you guys will get a copy of them. All the links are active. So the things that I touch on real quick, there's more information going to be available after those links. Just because
I don't know if this will work, but maybe it will.
That's all right. We'll just do this.
There you go.
So real quick, from the national level, the VA is not just one thing. We're actually three separate entities. You've got the healthcare side of the house, that's what we do. You've got the benefit side that does the education, it does the disability. And then you've got the cemetery, which pretty self-explanatory. Shockingly little information actually happens between these three entities, right? Because they're three separate benefits packages, right? So healthcare, what we're focused on is treating veterans. The benefit side of the house is trying to figure out how disabled somebody is to offer compensation or get them lined up with their benefits. So they've got a whole separate mission. And then obviously cemetery, they've got a pretty obvious mission, but people talk and they go, oh, you know, the VA, or I applied for this and they denied me. They just think it's the whole big VA. Chances are, if you have a DD 214 or you've served in the military, there are programs within the VA system that you're gonna be eligible for in one of these lanes. So I always connect folks with their county veteran service officer, just to make sure they're getting everything they're eligible for. Quick history here, we actually became a cabinet level department in 1989. Prior to that, it was kind of this slightly more broken, fragmented level of care and things happening for veterans. So that was a really big deal. So we do have a secretary of the VA. Quick breakdown of what we are. We employ about 427,000. It's more than that now. Last year, we hired about 65,000 employees nationwide. 29% nationwide of our employees are veterans. We actually do have positions at every hospital that are only for veterans, which is kind of nice to help folks transition. 172 hospitals, 1,100 outpatient facilities, 300 vet centers. They do just readjustment counseling there at the vet centers, 60 regional offices, and 155 national cemeteries. Raise your hand if you've heard something bad about the VA. Everybody, myself included, oh my God, it's so bad. You see that a ton. I personally saw that in my own transition. When I got out of the military, I'd absolutely wanted nothing to do with VA at all. Because of what I saw on Instagram, Facebook, and the news. I'm like, yeah, no, thank you. I'll just take care of my own stuff. And it really wasn't until my wife was like, hey, you need to go in there and see if they can help you, because things weren't going well for me. And literally the first employee I met was like, okay, she's cool, but everybody else here probably is, you know, gonna just try to deny and argue with me. And then I met the second person, I'm like, all right, they're pretty cool. Everybody else here, though, is probably what I saw on Facebook. And after a while, I ran out of employees to go, oh, like these people actually do care. These people are very focused on getting me better. Heck, my primary care provider, when I first got home, started every session with a hug. That's not what you see in the news, right? But when you look at these numbers, right, we're operating 172 medical centers, 1,138 outpatient buildings. I'm assuming you guys all work for healthcare facilities with quite a few employees. Do you guys have any bad employees that give out bad stories? I bet nobody want to raise their hand on that one. So we take the hits for those. So that's honest to God, in my opinion, one of the biggest barriers for veterans getting care is we get judged at that big national level, and they don't necessarily give the opportunity to the local facility. I can tell you from personal experience that if it wasn't for our VA in Iron Mountain, I would not be here today talking to you guys. I can assure you of that. So a couple of cool things that we've done. We've got 3 Nobel Prize winners. We kind of developed these different things. The first liver transplant, nicotine patches, cardiac pacemakers. I'm trying to rush through this a little
No,
bit.
you're good. You got 15 minutes yet.
Every hospital is broken down into what they call a VISN. So this is ours. We're part of VISN 12. It's the whole UP all the way down. You guys, for downstate folks, that's mostly going to be VISN 10, I believe it is. So we are kind of broken down. It's no different than any other company. It's just we're on a much larger scale. That's my home hospital right there. We cover 26,000 square miles. We are considered the most rural hospital in the VA healthcare system, even more than what you find in Utah, Montana, stuff like that. About 99% of our veterans fall into the category of either rural or highly rural. So we've got that comes with challenges and benefits. So just a quick overview of our facility. This is where all of our clinics are. So you see all the way down south to Menominee, Rylander, Ironwood, and then all across. So we have to cover that 26,000 square miles with 8 outpatient clinics and 1 main facility. So there's a lot of gaps, right? There's a lot of places where our veterans have to travel a long way to come and see us. And that's kind of where the Mission Act that Jim had kind of talked about came into play. It allows us to purchase that care at your guys' facilities, so that 96-year-old veterans don't have to drive 5 hours from Sault Ste. Marie to come get a simple MRI. We can just purchase that right in their backyard. So here's just a list of what we offer at our facility. This is typical of what's called a level 3 facility. I apologize for my ignorance. I don't know civilian healthcare. I've only worked in VA healthcare. So I don't know if everybody calls themselves level 3s, 2s, and 1s, but we're level 3. This is very typical of a smaller VA hospital. Is that true or no? Okay, so
Sounds like prison, but that's.
Okay. Yeah, so typically a level 3 is your lower complexities, stuff like that. Level 1s are bigger. This is a typical care package for a level 3 facility. You guys do have bigger facilities down in Detroit. We've got bigger ones over in Milwaukee, Madison that do some of our bigger surgeries and stuff like that. All right, we utilize telehealth a ton. We have to, covering what we do. So these are all the services that we offer through our telemedicine program. We've got tele-equipment available at all of our outpatient clinics as well as our main facility. And we have a pilot program, not a pilot anymore, actually where veterans can get care through their telephones, tablets, stuff like that. I don't know if you saw that giant map of the UP, most of that's forest. There's not a lot of reception up there. We have a ton of vets that don't even have access to internet. So we can provide as well iPads for them that have 3G on it and they can communicate with us that way. We have a veteran transportation network. It goes from each one of those outpatient clinics for free and it will bring veterans to the main facility. And then we also have a big bus that will bring veterans from our main facility to some of our bigger hospitals. So if they do need a more complex surgery, we make that happen for them. And then just quality metrics, because from what I understand, you guys are mostly quality folks, right? So I was like, let me bring some data for them. I know they like that. Hopefully, you said no, but sorry. I didn't mean to call you out.
It's okay,
So,
as long as it's not a policy, we're good.
no, I'm not talking any policies at all. Our facilities, you can tell right here, we do very well. We're in the top quintile across the board. Our CLC has a 5-star rating from the Centers of Medicare, Medicaid. We've been pretty consistent in our 5-star rating across our hospital since the inception of that. And when they started offering it for outpatient, we've hit 5 stars as well. So it's pretty exciting stuff. It's not just comparing VA to VA anymore. Now we're being compared to our civilian counterparts. And at least up in Iron Mountain, we are doing very well. A couple of metrics I like to pick on is overall hospital rating. We do that through a program called SHEP. The Centers for Medicare, Medicaid have their own way of measuring it, but now it crosses over nicely. So in 21, 88%, in 2023, 89% of our veterans gave us that top box score. Very proud of that. Overall rating of our primary care providers, again, we do fantastic. And overall rating of our specialty care providers, very exciting. And if you really dig into these numbers, like I like to do from time to time, you'll find that even below that 83%, we're getting a lot of 7s and 8s. It's not a lot of 1s, 2s, and 3s. In 2018, Big VA said they wanted to start celebrating hospitals that were doing very well. And they started kind of grabbing all of this patient experience data and then awarding top hospitals. Again, we'll use the level 1, 2, and 3. So they do best overall, and then they do a best level 1, level 2, and level 3. Since they started giving out the awards, we've won one every single year, 2 times taking best overall in the country. Very proud of our little facility up there. And then we've got the standard accreditations that most facilities have, Joint Commission, things like that. Or at least my understanding, because again, I have no idea how civilian hospitals run. If you guys are interested in reaching out, or you have questions after this, or you saw something in the news you had a question about, my contact information is available on here. And then the patient advocate office I left on here just because that's an important resource for not only veterans, but you guys as well. If you meet a veteran, come across the veteran, something's not making sense. Every hospital has a patient advocate program. It is monitored at the hospital level, the VISN level, and the national level. So there's a ton of oversight in our advocacy program. So please, please, please take advantage of that. All right, PACT Act. I'm just going to touch on a couple of things because Jim did a fantastic job with this. These are sort of the areas in which they look at for those exposures. And I can tell you that most veterans at some point will have encountered something that's in one of these categories. And I do have links to the entire list, but it includes stuff like dust. Like for instance, in Iraq, they found that a lot of the dirt has different nerve agents in it, stuff like that. So even very mundane routine tasks in the military sometimes do lead to these exposures. That's that phone number I told you guys about. Veterans can call this and directly enroll. And if they're enrolling under an exposure, so if they're saying, hey, I served in Afghanistan, for instance, and I was exposed to burn pits, the folks at this number will be able to look up that veteran's chart see where they were at, see what they were exposed to based off of their military records. So they'll be able to adjudicate that right over the phone. Now, if a veteran is shown to be exposed to something like, so for instance, myself, I served in Afghanistan, I was around burn pits. If I call that number to enroll, they don't care how much money I make. I could make $10 million a year, but because of that exposure, I am now gonna be eligible for VA healthcare. Now, here's just a list of websites. Again, this is less me covering and more if you guys are bored tonight and you wanna click on stuff. This registry, this is our dashboard. This kind of tells you how many people we're pulling in under the PACT Act and how many benefits claims are being paid, if you're into that. And then down here's the list of military exposures. That is an interactive list. So if you know a vet, if you're married to a vet, if you're a vet yourself, check that out. And you can literally go on and click on MOSs, which is military occupational specialties, sorry. And it'll break down, oh, this is what we kind of expect that exposure to be. Or areas in which people served or different stuff. So if you're wondering what those exposures could be or how detailed they're getting, that is a great list to check out. All right, Mission Act of 2018. This is what really, I think, in my opinion, applies to you and what I really hope you guys take away from this. In 2018, we really got an opportunity to change how we interact with civilian hospitals. Prior to that was a law called the Choice something Act, whatever. That was rolled out in retaliation to, or I don't know if you want to say retaliation, but basically a bad news story out of Phoenix, Arizona. And the president said, fix it immediately. Congress passed this bill and they're like, roll it out. And as you can imagine, with a nationwide program being rolled out in, I think, like maybe 90 days, 180 days, it had problems. The Mission Act is the fix to that. So the Mission Act, they gave us an entire year to get the framework in place before it went live. That allowed us to hire an actual insurance company. I'm sure you guys have all heard of United Health. One of their subsidiaries, Optum, that's who we work with. They handle all of our billing. So we approve the care, we send it out. That comes with an authorization number that Optum's looking for to start paying those bills. Yes, ma'am.
So I have a question,
Yes,
because you're saying community provider,
yes.
and this kind of goes along with the approval, blah, blah, blah. What about walk-in clinics?
So that's a really good question.
So they're not gonna have an approval because they're coming in at 7 o'clock at night, and then if we see them, then we're fighting to get that office visit
Yes,
covered because they won't do a backdated.
correct.
Unless that's changed.
It's actually changed for the worse. We used to be able to, because we were doing it wrong, backdate consults and move the dates. The law actually does not allow for that. So veterans do have to have their care pre-authorized no matter what, period. Two exceptions to that rule is urgent care, and it has to be an urgent care. It can't be convenient care.
So can it be billed out, if it's billed out as a rapid care, which would be like an urgent care?
It has to have urgent care, licensing in essence, and if it's not urgent care or the emergency department.
Correct.
Okay.
Yeah, and those are
So it
two
can't
totally
be
separate
promoted.
programs. So it does have to be urgent care, billed as urgent care, and you do have to be in network with VA. The Mission Act of 2018 was the first time we've ever been able to pay for urgent care out in the community. We locally have found out that a lot of our hospitals are converting over to that convenience care, which bills essentially as primary.
As a
care.
primary care. If it's billed as a primary care.
Then they
then
can't, see when we were sending out, but they bill rapid care and urgent care as not as a primary. They bill it as an urgent care. They bill urgent care now, yes.
If it's truly billed as an urgent care,
I'm
then
gonna
it
double
should
check
probably
and
be
find out.
qualified.
Yeah.
But if
And
it's
make,
billed as primary. it's not
Right,
qualified.
exactly.
and it has to be an in-network. So
That's, yeah.
some hospitals have chose to à la carte their enrollment. So their surgery department's enrolled in VA, their whatever department's enrolled in VA, but not the entirety of the hospital. Other hospitals just went full tilt and their entire hospital is in the Optum network. But the urgent care does specifically have to be in network in order for us to be able to pay that bill. And if you're curious, go on va.gov, right at the top, it says find locations. You can type in your zip code, hit urgent care, it'll pull up all the civilian and VA urgent cares within the search area. That's a really good question though. So real quick, because I don't want to miss this piece, because this is a part where a lot of our veterans end up struggling, is not getting that pre-authorized care. So our authorizations do have expirations. They have start dates and stop dates. And if a veteran moves outside of that, they will end up with a bill. I myself had that happen. I was going out for a neurologist and I'd been seeing him for 2.5, 3 years probably. And they just kept requesting additional services and I kept getting more services and they kept requesting. It was working great. I had no idea any of that was happening behind the scenes. I just kept showing up and it was working well for me. The problem is the person that worked at the front desk quit and the new person coming on wasn't as squared away in the program. And so she didn't submit the request for additional services. I got stuck with a bill. Now I pay attention to those dates myself. I make sure I have authorization. But this also includes, especially in urgent cares and emergency rooms, we see this a lot. A veteran goes in and they say, hey, my knee hurts. The doctor gets them bandaged up, taped up, here's some ibuprofen. Follow up with orthopedics on Tuesday, we'll get you an appointment. Once they leave that emergency room, that care is done. And now it has to get pre-authorization before they can see anybody else, even within the same building. But once that episode of care in emergency is done, that follow-up care has to be pre-authorized by the VA in order for us to pay for it. If it is urgent or emergent in nature, we can push those consults through very rapidly, but they have to say on them, this is urgent, this is emergent. Emergent consults are processed in 24 hours. Urgent, I think they have 72 hours. Your typical routine consult is gonna be about 14 days before it gets approved. So just something to keep in mind. All right. Here's the top areas in which we are paying for care. This is specific to Iron Mountain. I don't have access to the data of other hospitals, but this is a pretty similar list that I've seen, anytime I've seen other hospitals talking about this. It's about the same care that we're buying out in the community. So if you guys are curious to look at this, these are areas that we need help in. So if you have it, let us, sign up, please. This is just for volume purposes. So you guys understand the amount of consults we're sending out. So I mean, just in March, we sent out 5,200 consults into the community. That's pretty massive for a hospital that literally treats, I think we have roughly around 25,000 enrolled veterans in our healthcare system. And we sent out 5,000 consults. Now it's at 5,000 individual people. Some, one person might get 10 separate consults in a month, but just volume wise, what we're purchasing out in the community. All right, are there any questions? How am I on time, Daniela?
Yeah, probably not. No questions.
Four
All
o'clock.
right, I have mine early.
I was like, these people haven't had a break. They are gonna wanna get out a long time.
Yeah, a couple other definitions I've seen, quick care, rapid care, and convenient care, and that's making it all kind of confusing, so it'd be an urgent, emergency.
Well, and it just, they bill as an urgent care, but the name is different. And you have quick care, you have rapid care, you can have an urgent care, and they may all bill under that urgent care.
Yes. And then it has to meet up with the VA code, all that has to mesh together.
Yeah, I'd be able to explain physics to you more than I can diagnostic codes. I just,
Okay.
convenient care doesn't work.
So
But I
for
know, I know urgent care within RHC, there's.
It's primary care. It's
Yeah,
urgent care under
primary
RHC is
It's
not
meant
a
to be
PPO.
outpatient
Part
facility.
of it used to be, and then.
It's an extended care.
It's under the RHC.
Any questions for Jim and Tim?
And like I say, I'll have a table set up out here, tomorrow or the next day. I think, I don't know how long Tim's gonna be around.
I'm here till Friday.